Welcome to the Pomeranz Mentor Series presented by ProScan Education Foundation. And the vignette that we're going to cover today is focused on the hip, specifically the labrum and femoroacetabular impingement and pathology. The normal labrum does not circumscribe the hip 360 degrees. It makes a horseshoe, as depicted here in blue. The bottom of the horseshoe is bridged by the transverse acetabular ligament, which some have likened to a St. Andrew's cross. Coming up from the bottom of this ligament, a ligament to ligamentous connection, is the ligamentum teres, which has two components, an ischial one and a pubic one. They've not been separately drawn in as yet. The femoral head has been disarticulated out of the joint to allow you to see the anatomy a little bit better. The cup is deepened by a combination of hyaline cartilage and a thin fibrocartilaginous rim, which is contiguous with the adjacent acetabular bone. The femoral head should have a nice congruent fit with the acetabular cup. We'll define that in greater detail shortly. While there is some blood supply that enters the hip via the ligamentum teres, it's the minority of the blood supply, less than 15 or 10%, the majority coming from the circumflex femoral vasculature. The hip is not important for load transmission, but it is very important for subtle twists and turns, rotational changes, as well as subtle AB and adductions that help support the stability of the body. Overall, the labrum is composed of dense fibrocartilage. If you cut it in cross-section, it's triangular in shape. It has a well-defined apex. Posteriorly, it's more triangular and it's more substantial in its overall size. It has attachments, as stated, to the transverse ligament inferiorly and to the acetabular rim. This series of MR studies using an arthrographic laden or a water-laden sequence highlights additional anatomy. First, the joint space is filled with high signal intensity fluid, allowing visualization of the transverse acetabular ligament and the ligamentum teres, which has a broad insertion on the fovea capitis. Do not confuse the smooth, round sulcus between these two structures for a tear. A tear will have a more focal, angled, serrated, knife blade-like configuration. There is a larger inferior recess just medial to the transverse ligament. This recess ends at the attachment of the capsule to the femoral neck. Sometimes this attachment is not discretely seen, but it can be inferred by the pointed shape of the tissue as it approaches the tapered, gracile, delicate femoral neck. Some of you are wondering what this structure or structures represent. These are not part of the capsule. They are synechiae or plicae, otherwise known as plicae of the inferior recess. Laterally, the fluid outlines the iliofemoral ligament. The iliofemoral ligament helps form the lateral aspect of the capsule. It rides above the labrum. A small space exists between the two, the paralabral recess. In young individuals, this space should be less than 1 to 2 millimeters above the junction of the fibrocartilaginous and acetabular labrum. But as you age, this space may strip a little bit and lengthen to about 3 or 4 millimeters. But this thin-like slit hyperintensity lateral to the labrum is normal. The indentation that one sees here represents the attachment, although we don't see the actual attachment. It's a little more posteriorly of the lateral side of the zona avicularis. So this line will delimit everything that is intra-articular, and below it, everything that is extra-articular. So this would be the low neck, the mid-neck, the high neck, the head, the subcapital area, the supratrochanteric area, but outside the joint space, the intertrochanteric area, the subtrochanteric area. If we place an oblique line corresponding to the long axis of the femur, we'll obtain an oblique axial section. This gives us some of our best views of the reflection of the anterior and posterior capsule, which define the zona avicularis. Everything to the left is intra-articular. Everything to the right is extra-articular. As we have a strong, thick capsule and iliofemoral ligament in the front, we have a more variably developed capsule in the back, the ischiofemoral ligament. Although not seen, it is common to see ischiofemoral ligament region plicae, although frequently they are unnamed. It is common to see a relatively deep sulcus posteriorly, but that sulcus has an organized appearance. It's smooth, it's triangular, and it has a slightly rounded tip. Around it is the perilabral posterior recess formed by the ischiofemoral ligament and capsule and the labrum. At the level of the joint, this dark signal intensity area is not the ligamentum teres. This is a fat-suppressed image. It's too big to be the two leaves of the ligamentum teres. It's simply fat that has been fat-suppressed. This fatty tissue is known as the pulvinar of the hip. Now, the microscopic anatomy of the labrum consists of layers. There's an articular surface made of a fibrillar network. There's a laminar layer of collagen fibrils, and then from inside to outside, externally, there's a main layer of circumferential longitudinal collagen fibrils that blend with the transverse ligament. So just as in the shoulder where there is a labroligamentous complex, so too in the hip there is blending of the outer fibers of the labrum with the inferior transverse ligament of the hip. The blood supply to the hip comes from capsular vessels that are given forth by the retinacular vessels and circumflex vessels, not so much by the ligamentum teres vessels. The function of the labrum, as stated, is to deepen the joint, to help seal the joint, and to distribute forces. Here's an example of a superior labrum, the grayer tissue, and one gets a feel for the outer fibers, which are a little darker, the middle fibers, which are a little grayer, and the inner fibers, which are a little darker again. One also gets a feel for the sublabral sulcus. The sublabral sulcus is more prominent anterior and antero-inferiorly. As you go back in a coronal projection, that sublabral sulcus should diminish in conspicuity. Its depth, there's no set rule, but as a guideline, no more than a third to a half the depth of the labrum should be breached. I use a third here to a fourth. But in some patients, you can have a really deep one. But if you do, the top of that sulcus should be a sulcus. Sulcus means round. It shouldn't be a knife blade, sharp-edged, tapering fissure, nor should it ever be accompanied by a cyst. Its angle is approximately 20 to 30 degrees off the vertical. It will persist into the anterior quadrant, so don't be dissuaded by that into calling it a tear. And sometimes there's confusion with the adjacent capsular tissue, or if you have a plica along the side, the so-called paralabral plica, it may be confused with a sliver-like tear that has been cleaved off the labrum. We have no such plica depicted here. But we do see the lateral capsule and the iliofemoral ligament in an adult with 2 or 2.5 millimeters of separation from the interface of the fibrocartilaginous labrum and the bony labrum, and that is normal in an adult. This is a recess. This is a sulcus. This is a normal labrum. Here's an anatomic view. A little hard to reconstruct in your mind, but let me help you. There's your acetabulum. This is the superior acetabulum. This is the inferior acetabulum. Here's the femoral head. So let's break out our teaching tool. So here's our labrum, and right here is our sulcus. Now let's follow that sulcus down. Now look at, as you go down, look at how smooth it is. Got a nice big black arrow on it there. And then as you go down, look at how it gets a little bit bigger inferiorly. You should not let that dissuade you at all, especially when you're looking at axial projections into the false diagnosis of a tear, as long as it maintains that smooth-edged, sulcus-like quality. It's a little-known fact, but it is a fact, that the anterior sublabral sulcus gets bigger as you go from craniad to caudad. Then finally, the last anatomic point I want to share with you is the hip plica. Hip plica or synechii or bands are common in the hip. But sometimes they can be in awfully confusing places. For instance, here is a paralabral plica. One might see that the inexperienced observer could confuse this with a piece of labrum that has come off, or some other structure, or perhaps an area of synovial thickening. But it's linear and delicate, and this happens to be a common location. You can get plica that occur inferiorly. This is perhaps the most common location, near the inferior labrum. And with all the recesses and the ligamentum teres and the increased size of the normal inferior recess, one sees that the presence of an inferior plica makes your visual dissection of the recesses versus pathology a little more complicated. But plica are thin. They go back to the surface. And then again on the right we see our paralabral plica superiorly, and we can compare some of these plica with actual plica on MRI. The coronal projection shows a relatively large inferior recess plica. No, that is not the transverse ligament. There is a sagittal view. That is the inferior capsule. No, that is not the transverse ligament. That is an inferior recess plica. This coronal image demonstrates the ligamentum teres. No, that is not a limb of the ligamentum teres. That is the plica of the ligamentum teres. And finally, in the sagittal projection, no, that is not the iliofemoral ligament or anterior capsule. That is a plica within, lying just anterior to the labrum, and there is also an inferior plica. The last plica that you have seen on MRI, but now demonstrated to you on a diagram, is the plica of the ligamentum teres. It usually rides medial to the ligamentum teres, although may be tough to see if this space is very small. So an extra but much thinner band and much more linear will be seen depicted here in black as the plica of the ligamentum teres. Okay, I think right there we'll stop with our introduction to hip anatomy. You'll see that the hip is one of the most challenging of all the joints along with the shoulder. It is the joint with the smallest capsule, yet the biggest structures, which makes it difficult to fill. It's under a tremendous amount of pressure, especially with jumping. So the shear effects and compressive forces produce a unique compilation of injuries that are more prone to occur in people with various deformities, like impingement syndrome and developmental dysplasia as those underlying deformities. But that's a story for our next vignette. Thank you.